Hi, good morning, everyone. Thank you for tuning in at 8 o'clock on a Wednesday. My name is Rebecca Bally, and I am a Facilitation and Improvement Specialist with the Oregon Healthcare Quality Corporation, which houses the Institute for Patient-Centered and Primary Care Institute. Apologies. My role for this morning's webinar on integrating community health workers in your practice is to moderate, but we have a wonderful presenter who will take the reins on most everything else. So before I turn things over, I just want to review a few things about the technology we're using today. Since we have so many of you on the line, everyone is and will remain on mute throughout the presentation. However, we will have plenty of opportunities to solicit feedback from you, and we do want you and encourage you to participate. If you would like to chime in via your audio connection, you can raise your hand. There's a little hand icon next to your name, and you can just click in that box. Also, you are welcome to submit questions via the questions pane on your control panel to the right, which is shown here on the slide. You can type away, and I'll read your question for our presenter to answer. Please feel free to also send me, Rebecca Bally, or my colleague, Marissa Sweeney, any questions if you're having technical issues, if you can't hear us, if you can't see slides, if there's anything else that we would can try and troubleshoot for you. We will send all webinar participants a link to the recording of today's presentation and the slides and additional materials after the webinar. There are also a couple of places today where we will be polling you. And for today, we're going to be soliciting some comments through the polls, and so we'll need to do that through a Poll Everywhere app, and we will chat in a link to a web link that you'll need to click on or copy paste into your web browser to respond to that. So just be prepared with that. Have the web browser open. And I think those are everything else. If you have questions, again, please feel free to chat those in the question pane. Very quickly, a little bit about the Patient-Centered Primary Care Institute. It is a public-private partnership that was launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation, and it's managed by the Quality Corps. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. So we work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality of improvement in Oregon. We encourage you to visit our website at www.pcpci.org to access additional resources, including previous webinars. And you can also sign up for our email list on the website, which is how we will announce additional web-based and other training opportunities or institute programs for the future. Very quickly, as I mentioned, the Institute aims to help primary care practices achieve recognition as primary care homes throughout the state of Oregon through their Patient-Centered Primary Care Home, PCPCH program. The model is a set of standards organized under 6 core attributes, which are listed here. And you can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. So without further ado, I would like to introduce our fabulous presenter for today. Lisa Ladendorf has served as the founder and director of the Northeast Oregon Network, NEON, since its inception in 2004. As a part of NEON's consulting services program, Lisa provides organizational consulting, grant writing and management, program evaluation, and technical assistance services to health-oriented organizations, both in the region and the greater Western United States. She has a 20-year history of clinical practice as a licensed clinical social worker, specializing in the dynamics of behavior change, including health behavior change, and has served as a local public health administrator for 4 years. In addition to her work as a licensed clinical social worker and serving as NEON's director, she has trained, mentored, and supervised public health and community mental health leadership staff for over 16 years. She is a registered community health worker and a community health worker trainer. So we are so thankful and grateful to have her here to share with us today. And without further ado, I'll turn it over to you, Lisa. Don't forget to unmute yourself, Lisa.
I just glanced at the registration list and see that we have folks from all over the state, urban and rural, as well as some folks from out of the state. So I'll be pleased to be hearing from you all too as we go. Let's see if I have it. There we go. So the learning objectives for today, we noticed in the questions that you all had sent in with the registration form that many of you are at least somewhat familiar with community health workers. And so what we were planning on doing today was not so much in terms of theory or research, but really a deeper dive into some of the practical issues of integration in a practice site. So our learning objectives for today are to explore methods to ensure a match between skills, qualifications, and the requirements of the job, to learn how community health workers will change the practice workflow and interactions with patients, to understand how to add community health workers to a team in a way that both maximizes their role and fully supports their needs, and track emerging models for sustainability. So we wanted to first do just a really rather quick high-level overview of community health worker definitions, just to make sure that we're all working from the same framework. So I start with the American Public Health Association definition that a community health worker is a frontline public health worker who's a trusted member of and or has an unusually close understanding of the community served. And those words are highlighted because when we talk about the most important qualification for a community health worker, that's really it. When we talk about the magic of what community health workers can do and the outcomes that they can help you achieve with patients, that element is the most important element to be present in order to get those desired outcomes. So, and the reason is that trusting relationship really enables the health worker to serve as a liaison, a link, and an intermediary between the health and social services arenas and the community. And that linking and liaison function really helps facilitate access to services and, most importantly, improve the quality and cultural competence of service delivery. So we've also provided you with the Oregon definition of community health workers, because for those of you that are in Oregon, this is sort of the governing definition that is enacted in statute. It talks a little bit more about what a community health worker does as opposed to who they are, which is more of what we see in the APHA definition. It does talk about them needing to share, to the extent practicable, sharing ethnicity, language, socioeconomic status, and life experience. And then this definition sort of goes into some of the functions that CHWs are able to perform in Oregon. So provide health education and information that's culturally appropriate, really increase the capacity of the community to meet the healthcare needs, assist residents in receiving the care they need, may give peer counseling and guidance on health behaviors, and may provide direct services, first aid, blood pressure, and screening. So we're going to talk in a little bit about some of the training and skills when we get into developing job descriptions. And some of what they actually do, of course, is going to be dependent upon your sites and your needs. So this is a picture of the Oregon community health workers throughout the state that are members of the Oregon Community Health Worker Association. And I just briefly wanted to mention that community health workers in Oregon, although there's been a lot of recent attention since 2013, They really began in Oregon in the 1960s with the Indian Health Services. And then in Hood River, El Niño Center, working with migrant and seasonal farm workers began in the 1980s. And since then, in the 90s, there were several areas in Portland, neighborhood health clinics, parish promoters, and Benton County Health Department that also began to implement. Now, of course, we're looking at a much wider spread implementation. So the Oregon Community Health Worker Association is housed under the Oregon Public Health Institute. One of our suggestions is if you employ community health workers, it's a good idea to support them and for your organization to join ORCHWA as a professional association. It's not an expensive professional association to join, and it's one of those functions that help link your community health workers with peers, particularly if you live in a rural area and community health workers are just being implemented. There may not be a wide body of peers present geographically, and it is really important to help support quality work, reduce isolation, and improve the performance of your community health worker to have them connected with peers. It's also a resource that you can go to if you are looking for help or assistance. We're trying to give you several resources to follow up with as we go throughout this presentation, and ORCHWA is one of them. A couple other resources that we decided not to go into because you can access these websites and we wanted to get more into the nitty-gritty of integration in a practice site. If you are looking to see what the availability is of community health workers for hire in your area that are already trained, you can go to the Oregon State Registry for registered traditional health workers, do a search for your geographic area, and we'll be able to determine who is already certified in your area. There's a link for the Oregon State Traditional Health Worker Rules and Policies. This comes from the OHA website, and it will give you some of the state level regulations governing this. And then there's also a link to state approved training programs if you have someone hired and or already working in your clinic and you would like to have them trained. That'll give you a link to state approved training programs. So right now, before we go any further, we just wanted to see if anyone had any questions because we kind of went through a lot of that quickly. So we thought we'd give you an opportunity to please chat in if you have any questions at this moment.
Hi, Lisa. So far, the only question has been whether the slides will be available later, and yes, the recording, slides, and all additional materials will be.
Are you, Marissa?
Yes, can you hear us? Yes, can you hear us?
Okay, I don't think I'm seeing any questions come in. That's fine. We didn't necessarily expect folks to have them at this point. So we'll go ahead and swing on into the next section. And Marissa and Rebecca, if you see any questions pop up, please let me know. And as Rebecca had said earlier, if you have something, please chat in questions at any point. And if you have an anecdote or something that you would like to share, please just raise your hand and we'll go ahead and call on you. So the meat of what we wanted to talk about today was how to integrate into practice. We asked you all if you'd had any questions in the registration, and so some of the questions that we heard from you all about integrating into practice that you were interested in were wanting to know about workflow changes, were there weekly or monthly targets for patient interaction numbers, how to operationalize a CHW role in a care team, what's the effectiveness of CHWs, what are the next integration steps, pitfalls, barriers, how to begin the process, how to integrate into team care, etc. So we hope we will be addressing some of those, and like I said, we'll have some opportunities for questions at the end of this section. Okay, I just saw a question, and that asked, will the slides be available? And it looks like yes, the slides will be available at the end of the session. So in terms of getting to those questions, those are the questions we're going to be attempting to address, and we'll also have a time for questions at the end of this section if we did not get to your question. So really the first element, and I appear to have lost control of the, there we go, slides, there we are. So basically one of the most important things that I can say is that you want to ensure that you have a good match. So in bringing in a community health worker into clinics, in our experience, and we work with quite a few clinics that we're contracted with working through a hub to train and then help implement community health workers into practice sites. So we have had some experience in working, quite a bit of experience in working with clinics with this, and what we notice is that the community health worker is really bringing in a different set of skills and mode of operating into a clinic than what is often normally there. And so it's really important to find a match, because you're going to kind of be blending and melding two cultures, which is really a home-based culture and an office-based culture for provision of care. So when we talk about, I mean, part of why this is important, and we've seen this happen before, one example is folks hire someone to work in the community health worker job, and they're great during the interview, or they may already be employed and they're great in the office, but it's not apparent until you get them in the home-based setting that they're really uncomfortable when they enter out of the boundaries of an office and into a person's home situation. So there's some certain things in interviewing and in putting together your job descriptions that you're really going to want to check for. So two types of match that we're really looking for are cultural qualities match and a personal qualities match. And some of the match is going to be with your community, because the community health worker's focus is on working with community member and empowering the community member. It's going to be important that they're a good match to organizational culture and to community culture both. So some things to think about in match to your organizational culture. What's the communication style of your organizational culture? What's the writing ability that's required for documentation or other things within your culture? What is your culture around schedule and timing and style of dress? So some examples of that are if you have a community health worker who's hired to work with youth or teen populations, and they have a really informal, kind of hip way of speaking that works great with teens that they really respond to, but that other professionals find to be, unquote, unprofessional. And that's one thing that we've seen, is that the kind of communication style that may work well with community members to get them to open up may not be the same kind of professional communication style. Schedule and timing, you have to realize, and we'll talk about this a little bit later, that community health workers will really, they're going to be taking more time with your patients. That's part of the value of them. That's part of why you have them, is that they can spend time forming engagement and relationship, which can help connect with the patient as well as find out more information. I'm aware from working in primary care clinics that because of the tight scheduling that you have, and the things are very fast-paced, you got to move a lot of patients through, there's typically not a lot of time for communication. So that's something that can sometimes cause a rub. Community culture, you're going to want to think about, and by community culture, I'm really thinking about the population that you're going to want someone to work with. In some cases, in rural areas, that might be the entire community. In some cases, it might be you're really wanting to focus on working them with an older population. Other times it might be you're wanting to focus on a population with English as a second language. So you really want to think first about what's the population you're trying to reach and the health outcomes that you're trying to improve. And then think about matching to community culture in terms of race and ethnicity, language, whether they have rural or urban experience, their age and their income level. So some examples of that is, it doesn't mean that you have to have your community health worker be a perfect match in every way with the culture that they come from. That's not always possible. It is important that they have experience connecting with and engaging with that culture, however, and that they are trusted by that culture. I would say one exception to that is language is key, that if you want to have someone working with a population that has English as a second language, it's probably best if they speak that language. So some examples are, you might have a younger community health worker who's working with an older adult population, but in your interviewing of them, you find out that they have lots of older relatives, have spent quite a bit of time talking to and with elders, and really has an appreciation for stories and shared wisdom. So that's an example where there might not be an exact match, but they would probably fit well. I would probably say that if you're having to choose between someone who's a perfect fit for your organizational culture and someone who's a perfect fit for your community culture, is that in order to get the outcomes desired by community health worker, it's probably best to weigh out on the side of what the match is with your community culture, because your organizational culture can really learn to adapt more than you can expect that community culture to. Just a couple other examples, because I know several of you had really wanted to look for examples. One of the things in terms of writing ability that we sometimes see is that a community health worker may have a really simple, direct writing style, which is a very good match for patients that have low health literacy in terms of when they're writing task lists with them or that kind of thing. But it may be seen as not being up to professional standards by clinic staff and providers. So that's just another example. So what we'd like to have you all do now, and there we go, is we have a poll, and we'd like you all to go ahead and use the polling functions and just reply, what are some personal qualities that you might look for in a community health worker for your organization?
And Marissa will be chatting in the link. Again, you need to copy this link into your web browser, or just if it shows up as a link, you can click it, and it'll take you to the website Poll Everywhere where you can enter your responses. And I just want to make sure that everybody on the phone can hear us, that can hear me. Okay, perfect. Thank you. So as soon as people start responding, we should be able to see it. Perfect. Okay, we've got personal connections, cultural, diverse, providers.
Okay, and so Marissa or Rebecca, did you have any information on the poll? Okay, so it looks like we're having, you can see some of the qualities that are coming in here that you all are looking for. Compassionate, respectful, empathetic, having some experience, thorough, passion, knowledge, good listening skills. We see community in the middle there, personable, objectivity. Wow, we're getting lots of stuff coming in here. Great, this is great.
Excellent. Thank you, everyone, for participating and putting in your suggestions and ideas here. And then, Lisa, I want to encourage us to move faster.
Okay. All right. So thank you for sharing those. So here are some personal qualities that that come from community health worker research and experience from other sites of what folks say they're looking for and are successful. And many of these match what you already said. So shared experience, friendly, patient, motivated, non-judgmental, compassionate. These very closely match what you all had listed. I think I had seen someone list that they have personal growth, dependable, responsible, reliable, adaptable, supportive, and emotionally mature, a model for trying to live a healthy lifestyle. So these fairly well match pretty closely what you all were mentioning. And it is important to note that while we can train people in skills, it's harder to train them in qualities. And this is really a job type where you're going to want to have these qualities and know that there may be some skills that they might be lacking that you can train in, but that's probably a better way to go if they have a fair number of the qualities you're looking for. So some folks had some practical questions, and these are questions that we get here at NEON quite a bit about developing a job description. You'll use whatever format you have. Usually they have a job summary, key functions, minimum qualifications, and those qualifications are places that where we put in into our job descriptions not only the training or experience we want them to have, but also those personal qualities that we had noted before. And then we also put in ours work context examples. It's very helpful to have some concrete examples of what a person's going to be doing when they're in the field. We've put a couple links here for you for some sample job descriptions that come from a couple external sites. NEON also has job descriptions that we're happy to share. You'll have my contact information at the end of the slides if you would like us to share any of our job descriptions. So getting a little bit about the other question is what to pay folks or how to determine that. And we typically do a salary survey. You can kind of see here the national median hourly rate and then the state median hourly rate. One of the things that's nice is a couple years ago, the Oregon State Employment Department did not have a salary survey, did not have a job classification for community health worker. They since have created one. So that's basically in Oregon the source that we go to. I've put the link here below for you to click on. That will take you to the search page. If you just click on the note that says look up wages and job info and type community health worker into the search box, it will pop up all sorts of information, not just the salary survey, but also suggested listed qualifications that you can use for your job description development. So I wanted to talk a little bit about changing worldview. There were many questions about how to integrate community health workers into the practice setting, and what we have noted is that really there's somewhat of a, and those of you that have already implemented community health workers may have noticed this, there's somewhat of a worldview change within a clinic that needs to take place. And much of this worldview change that needs to take place is really right in line with a lot of the elements of what you're looking at with your patient-centered primary care home efforts as well. So community health workers are excellent additions to a clinical team. They really promote a focus on health equity. They also focus on engagement, and engagement and relationship are the key mechanisms by which they work, and they focus on promoting health by promoting patient empowerment. So those 3 E's are really key to the worldview of what a CHW will be doing. We've outlined a couple worldview similarities between patient-centered primary care home clinic-based care and community health worker care. So we see in both of these that there are values team-based care. So patient-centered primary care home is all about team-based care, and community health workers, when they're trained, are really trained specifically in how to work as a part of a team. That's part of the Oregon state standards that are required to be addressed. Patient-centered primary care home focused on patient outcomes, and community health workers' focus is really to work with the patient, to have them set goals, and to assist the patient in meeting their goals. Patient-centered primary care home has a stress on the importance of care coordination, and a primary function of community health workers is to work to coordinate health and social service resources. So there's a lot of alignment there in terms of worldview similarities. Here are a couple things that we have noticed as we've worked with community health workers and sites on where there are some worldview differences that you need to be aware of, that it will be helpful if from the very beginning you can help meld and align these 2 areas. So clinic-based takes place in the clinic, obviously a structured setting, and community health worker-based care takes place in community and home-based setting. Usually clinic-based may have 15 to 20-minute visits, and that would 20 minutes would be a long one. Community health workers may have an hour or longer when they do home-based visits. Clinic-based care is often health problem focused. What's their health problem that they're coming in for today? And certainly there's a shift to wellness visits and preventative care, but a lot of how that medical model is driven is health problem focused. And the community health workers really focused on what are the assets that you have in your life to help you meet those goals, and what are the barriers that you have in your life that are preventing you from meeting those goals. Clinic-based care often has provider-driven communication, and that's largely as a function of time. And community health workers are going to have patient-driven communication. This is one of the reasons their visits take longer. Clinic-based care, there's typically very clear boundaries. There's boundaries around timing, there's boundaries around space, and once you get out into a community setting or a home-based setting, for those of you that have done it, it sort of disrupts those boundaries. They become a lot less clear. Clinic-based care is faster paced, and CHW-based care is slower paced. So these can sometimes provide some issues when folks are working at integrating. We wanted to just ask a quick question to chat into the chat box. If there are other either worldview similarities or worldview differences that you want to chat in, that you have experienced, noticed, or can think might arise. While you all are chatting that into the chat box, I'm going to go ahead and just give you a couple examples of how this worldview difference might take place. So you might have a community health worker that is really used to having longer conversations. That's what they do in the home, and is to engage and spend time eliciting and in conversation. So one place where those worldview differences can clash is if you're doing a warm handoff. So the provider is assigning a community health worker, you do a warm handoff who comes in to speak with them for the provider to introduce them, and then spends a couple minutes speaking with them. What can happen is they might then spend time beginning to chat and engage and connect, but what that can do to the clinic is get the clinic schedule off schedule, because that room is needed for the next patient. And that can cause some stress and tension and rub. So when you're integrating, you're going to need to be specifically aware of these particular issues and really address them ahead of time. So when you're training your CHW, you might say, when we have you come in to do a warm handoff, we need you to take just a few minutes to do that. Or you might have a separate room that's not a clinic room that they can go to talk. Those are just some examples of how you might preventatively head off some of those tensions that might arise. So do we have anything, Rebecca, I'm not sure if I'm seeing, do we have anyone who's chatted in any feedback on worldview differences they notice?
Hi, Lisa. We have not had any responses to that question, but there have been several other questions that maybe we can address now. And I have you on mute really just briefly while I ask the question so there's not the echo. But one question was, do you train your healthcare providers to understand and accept CHW's work?
Yes, we do actually. So, and we do that in two ways. One is that we offer a community health worker supervisor training that is a 2-day training, and we encourage folks who will be directly supervising to attend. We cover what the community health worker role and function is. We cover some of these differences and issues, and we talk about supervision models that will be helpful. The second thing we do is that whenever we work with signing up a clinic to work through our hub, we spend time talking with the administrators and the high-level practice managers as well as physicians, and in a much shorter form we orient to community health workers, the hub, and a few of these issues. And then finally, we're involved in ongoing technical assistance with the sites. So if something comes up, we can be there to help sort of navigate these waters. The thing that happens that's unfortunate is if folks are not aware of these things, it can begin to be personal. This community health worker isn't working out, or the community health worker feels not supported in the situation. And what we encourage people to do is back it off from the personal piece and look at it in terms of this worldview difference.
Perfect. Thank you, Lisa. And then we did have someone who submitted their suggestions for worldview differences and similarities. Thank you, Renee Smith, who said, CHW is seeing the broader health implications of social determinants of health, not always seen as a direct link to health outcomes, such as poor housing, lack of transportation, and food insecurity. So thank you.
Yes, thank you for that. That is definitely true. That while the clinics, I know, try and have a broad base of that, that's often not their primary focus. And for community health workers, that often is one of their primary focus, is really assessing and seeing how that impacts and meeting those needs. Okay, thank you. This sort of takes us into our next area. Having a little delay. There we go. Supervision implementation. So we had some questions about supervision, and it is really a key component. Especially if you have new community health workers, or if you only have one community health worker, and many small practices will start with this. So community health workers will need ongoing support and professional development after initial training. Remember, these are folks that are already connected to the community. That is their strength. They've had some basic training. They're not trained in many of the things that other new staff, including MAs, will be trained in when they come into your site. So there's an assumption that ongoing support and professional development is crucial to their success. Home-based work often gets messy. Anyone who's done that can attest to the fact that it is not contained. It intentionally erases boundaries when we go into the home. That's why we do it, because we get a better connection and more information. But it does erase boundaries, and so community health workers will need ongoing support in boundary determination and setting. And community health workers will often face challenges of engagement in relationships, things of a less medical nature. So they're not so much going to need to talk with you about what an appropriate course of treatment might be, but they might need to talk with you about a person that is is experiencing problems changing, and that's showing up as resentment or defensiveness. So a lot of that is going to be about resources and how to navigate through relationships. So one sample of that I'd love to share is I have a great story from my early days of working with community health workers, and we were doing an intensive home-based treatment program for adolescents who would have been in inpatient treatment for substance use and had hired community health workers to do a lot of home-based work. And I came into work one morning and had our person who was doing this work approach me and say, "You need to talk to the juvenile department and the police. They're really mad at me." And I said, "Why are they mad at you?" And she said, "Because I took some pot over to them this morning." And I was like, "Okay, you took pot over to them this morning? Why was that?" And anyway, this whole story had evolved that there was an adolescent living with his mother, and the mother made her living by doing daycare. And the adolescent had been using drugs and decided that, like, at one night at 9 o'clock, that he wanted to stop now and wanted to get rid of all his drugs and get it all out of the house. Mom had not known drugs were in the house. They called the community health worker, and this was part of our structured program that we had someone on call during these hours. Went over, and the mom was adamant that the police couldn't be involved because if they'd found out that there had been drugs in the home, it would risk the certification for her daycare, which was her only living-in way of supporting. So in terms of making a judgment call, the community health worker decided it would be best for her to take the drugs. Everything was closed, so she transported them in their car, kept them overnight, and then turned them into the police and the juvenile department the next day. So that created a big brouhaha. Certainly we can see where the community health worker was coming from and the choices to help preserve the family at that point. And we realized we need some policies about what to do in those situations so that our community health worker doesn't end up transporting drugs. So these are the kinds of things that can arise when you get into a home-based setting that just never come up in an office-based setting. As far as who supervises, there have been some questions about who should supervise, and there's sort of a dual answer to that. So technically, legally, in terms of billing, when you get to looking at Medicaid or Medicare, if CMS funding is involved at any point, there are regulations that the community health worker needs to be officially supervised by a provider that's either a physician or a nurse practitioner or a licensed clinical social worker. That's fairly restrictive for a lot of sites and can present a barrier. What most sites typically tend to do, if that comes into play because Medicaid billing is an issue, is they have that person, sort of the official supervisor, who may periodically review cases and sign off, but that provider does not provide the day-to-day, week-to-week, more intensive supervision. That's actually delegated to someone else in the organization. So some of the folks that provide the day-to-day, they can be a nurse. It can be, and we found that RN care managers may be better suited to that in terms of what their training and job functions are. It can be if you have an experienced community health worker on site who has a number of years under their belt, they can play that role. Or if you have a social worker, that's also someone that can play that role. Basically, the supervisor is going to need to have an understanding of community health work, an understanding of what it's like in the home, be available on a regular basis for quick check-in calls, and have, at least in the beginning, a weekly time where they can sit and talk and provide a space for reflective learning. That need may lessen as time goes by, but we encourage people to start with a higher level of support from the supervisor and then back that off, as opposed to starting with not enough support. So we have a question, and And this is, what sort of infrastructure do you think your practice might need to develop in anticipation of bringing in a community health worker? And this is another poll question.
And again, like last time, please cut and paste the link that you see here into your web browser, and this poll should show up. If it doesn't, please let us know, and then go ahead and type in your responses, and we should all be able to see them. Great, so we see supervisor with time and knowledge, buy-in from providers and other clinical support to the idea of a CHW, having nurse case managers involved who can oversee and then develop a care plan that involves providers, trained supervisor referral system, place in the EMR or EHR for documentation, thorough onboarding and support during orientation. Thank you, everyone, for putting in these responses. These are great. Care coordination.
Great, thank you. I also see flexibility with HR policies, hiring those with criminal history, collaboration with outside agencies. That's wonderful. Great thoughts, and you all are correct on all of those. So I'm going to go ahead and move to our next slide. This is just a little infrastructure checklist of some things that we have found have been helpful. In addition to all of the things that you all mentioned, it's a very good idea to have a home visiting policy that includes home visiting safety protocols. It's extremely important. If you all would like samples of those policies, please just go ahead and email me after the webinar is over. We have policies that we're happy to provide. Very practical nuts and bolts things. Cell phones enabled with text. That's also another important safety feature and piece for folks for staying connected when they're out in the community. Oftentimes, at least a basic laptop. We have found folks haven't needed a high-end laptop, but the basic laptop and the ability to connect via wireless or hotspot in patient homes. This may be a budget item that you might not normally budget for cell phones with text, wireless, or hotspotting connectivity in laptops, but those are important tools for them to have in the home. Mileage reimbursement support, which also may not be something that you have on a regular basis. Supervisors who have some training and an understanding of community health worker history and roles, as well as an understanding of the current functions and challenge. Dedicated supervision time, as you all mentioned, that is long enough to allow for reflective learning, so 15 minutes probably won't be enough. And then to be connected to other peer CHWs. So sustainability. Many of you asked questions about, I guess I should ask you before we go on, Marissa, Rebecca, do we have any questions?
Yes, we did have one question about, I think it was similar to a previous question that was asked, but slightly different, about what is your experience with anxiety of medical personnel about CHWs stepping into medical roles? Oh, hold on a minute. Let me unmute you. There you go.
Okay. That's a great question. I think that there can be some, is definitely what we've noticed. So related to that would be that your community health workers, at least in the state of Oregon, when they go through the training, are not going to have training in how to do med distribution, how to do blood pressures, how to do vitals, etc. That's not something that's in the current Oregon State curriculum. So if that is a role that you're going to want to be using them in a home-based setting, you're going to need to make sure that you have processes to train them for that. Those are roles that they can be involved in given Oregon state statute, but that would be additional training. One of the things that we've probably found that makes the medical personnel less anxious is if they can be involved in some of that training, and if those functions are to be performed, and that they can also be involved in some type of demonstration or testing capacity. We've actually found that there's probably more nervousness on the part of nurses regarding these functions than there is particularly on providers. I would also say that anxiety level varies with how supportive folks are of having them come on. So if a provider is somewhat reluctant about this as an organizational change, their anxiety is probably going to be higher. If they're desiring that, it's going to be lower. So it might be a good idea to do a survey of providers and medical staff first to see what their anxiety level is, and that might let you know as you integrate how fast you can go with getting them up to speed with functions and how you need to involve providers in training and or testing of those more medical competencies.
Great, thank you. One follow-up question really quickly before we move on to reimbursement models is what kind of quality assurance or monitoring do you suggest, for example, frequency of home visit monitoring, et cetera? Also, regarding onboarding or training, do you use a competency checklist? If so, who's involved in validating demonstration of those competencies?
Okay, yes, all very good questions. So for quality improvement, yes, we do have some recommendations regarding supervision, and that's one of the things you're going to see here in a minute, how much time is spent. Some of that depends upon risk level of the patients that they're working with, and there'll be a tool we're going to get to here that will give you some information on that. We do have some quality improvement policies that I'm happy to share with folks after the webinar if you'd like them, in terms of what types of reviews to do. There's documentation check and reviews, there's case staffing reviews, how often that should happen, and we do have some policies around that, and that do include some specific things that folks are looking for when you're doing that. As far as competency checklists, so we are also a training program. We've trained most of the community health workers that we're working with that are deployed in the sites. At the end of the training, we do some demonstrated competencies. We also have written competencies and are checking for competency all throughout the training. We leave other specific competency checks up to the practice sites, so that would vary from practice site to practice site. So quickly, a bit about sustainability. As most of you probably already know, unfortunately, there are not some easy, clear pathways for widespread reimbursement at the moment. So I'll just go ahead and say that right off the bat, that that's still an issue and a struggle in the state of development, and I encourage everybody to advocate and talk with payers about the importance of this. So just some quick examples. So direct community health worker reimbursement. So fee-for-service, your CCO may have some type of fee-for-service reimbursement. For example, the Eastern Oregon Coordinated Care does have some reimbursement for use of community health workers, but it's in an education-only model. So they don't reimburse for navigation, for social services, but they do reimburse for health education pieces. You'll need to check with your CCO on that. I kind of lumped under value-based, although not all of this is strictly value-based. If you happen to have a Pathways Community Hub operating in your area, there's a payment for outcome for resolution of needs. And so NEON is a Pathways Community Hub. With those that we contract with, we make payments to them for value for outcome. You would need to check and see if there's a hub developing in your area. A lot of folks in the region that I'm aware of, that I work in, have funded community health workers through transformation grants. That's not a permanent way or an ideal way, but it is a way to get started. And then often FQHC and migrant health centers have written into their particular funding grants, have written community health workers in directly. We also have worked with sites that have sort of had indirect ways of increasing their overall funding that allowed them to have enough to hire community health workers. So some sites that we worked with have really twinned this with an RN care manager position, and they've been able to bill enough and collect enough for the RN care manager that it creates enough to not only support the RN care manager, but to help support the CHW position as well. Your patient-centered primary care home value added per member per month. Some folks have chosen to allocate some of that for community health worker. And if you serve Medicare, there's Medicare chronic care management billing. This I believe it's a $40 a month. Folks have to have 2 chronic conditions. This actually is something that needs to be care planned in by the provider, so it's more provider-oriented in terms of the care planning piece, but can help bring in some funding where you can utilize community health workers to help implement that particular care planning. That's kind of the state of the state right now. Here are a few models for sustainability that talk about return on investment. With links to them, and so next steps. If you might be in 3 places. Maybe you haven't thought about CHWs in your practice yet, but you're starting to think about it, or you've made a decision and you know you want to incorporate CHWs but aren't how to get started, or perhaps you already have a community health worker but you're not sure if you're fully utilizing them. What do you do? So we want to pull this all together by introducing you to a practical tool that can help you get some focus. And this tool, I'm not sure if it's being sent out to you all. You can certainly contact me to get it if you'd like. I think it's going to be sent out to all of you, but I'm going to let Rebecca, is that the case?
Yes, it is linked on the website, and we will send it out via email.
Okay, great. So that's how you can access it. This is a tool we've put together that we use with folks in our region that are interested in this. And so it starts with really tab 1, which I'm not showing you. The first tab basically has you input sociodemographic information about the population that you're wanting to serve. Has links that go to the American Community Survey data, and you can input that information. That's going to help you get a sociodemographic sense of who your population is, what language they speak, what age they are, education level, so you can begin to do some of that community matching that we talked about. The next tab, which is the tab you see here, has some basic population health indicators and some links as to where that access, and this data is all at the county level. And this, you can certainly add more to this if you have a specific population. You can add more information to this, but this kind of gets it overall some population health indicators as well as some sociodemographic indicators such as social support and housing stress. This is going to give you some idea of what the health and resource issues are that your population is facing, which is going to give you and your community health worker some direction in the types of things you're going to be needing to do or need to know about. I will say that the data fields in this tool are not an exhaustive list. They're examples. You can certainly use either other standardized data sources, other fields, or add your own. We've got the next tools are, and it seems to be a little slow advancing. The next, okay. This is a little bit that gives you some ideas that we talked about. Workload, we have high risk, we have moderate risk, and we have low risk. There are a lot of different ways of how you estimate that. Again, if someone are interested in how we do risk classification, please follow up with me and let me know. It's going to give you some idea of times, number of visits, estimated supervision time, etc., and some examples of patient loads. We've also got just a simple way to put together a budget, some of the pieces that we talked about earlier, them needing. And then finally, we have a revenue analysis tool. So if you have someplace, and if you have questions about this, again, follow up with me, and we're happy to help see about how this might look for your area. This is making an assumption that you have someone that is doing some reimbursement for community health worker services. So that's just the brief bit about the tool, and I know we're getting at our time. So, but where are the questions?
Yes, there were a few questions, and I just want to say first, for people who need to sign off, thank you so much for tuning in today, this morning, and apologies for running a couple minutes over, but we would like to stay just a couple minutes to answer any questions. If you have to sign off, please feel free to email us your questions, and or you can take a look at the recording that'll be linked and emailed to you afterwards for responses to some of the questions you submitted. But let's see, we had some questions about are there national organizations to link health workers with peers if we are outside of Oregon?
So you might try checking with your state. Many states might have something. The CDC does, and HRSA, I know, do have some linking, but those may only be as it relates to folks that are funded via grantors. There's not, unfortunately, at the national level, most of this is taking place state by state, both standard development certification and professionals organizations. The one that did just jump into mind is I do believe the APHA, the American Public Health Association, now has a community health worker subgroup. That's the one national one I can think of.
Great, thank you, and thank you for the question. Lisa, another question we had was with English as a second language, customers, should the traditional health worker or community health worker be a certified translator?
It depends on how you're going to be using them. Ideally, your community health worker would be of that population themselves and a native speaker. If they're not a native speaker, you might want to have them certified in some way so that you actually know that their language really is up to par. If you're going to be using them as a translator in a medical setting as well, so let's say you're going to have their community health worker come to their visits with them, then yes.
Great distinction, Lisa. Thank you. And there was another question about someone who's wondering about the distinction and overlap between community health workers and social workers.
So a social worker typically in a setting will have a master's degree, so there's a much higher level of training that goes into that. They will also probably have some clinical training regarding therapeutic interventions in the psychological arena, as well as some community and systems assessment training and skills at a higher level. A community health worker doesn't have that level of training in all of those areas. So as far as treatment planning might go, formal community health system assessments, you would see your community health worker working under or working with your social worker.
Perfect, thank you. One last question, and then I'll check to see if anybody has their hands raised. The question was, can you give some examples of value-based contract expectations for example, what outcomes would you put in there?
Value-based contract expectations. So, I mean, that's an interesting question. A lot of value-based contracting, in my experience, is really going to be around, the outcomes that you're able to produce. So let's say you're managing a diabetic population and you're able to reduce some of their specialty care services, or you're able to keep A1Cs within a certain limit. It depends upon, my first suggestion would be, what is of value to the payer for the value-based contracting is going to be the first question, and is that a utilization question or is it a clinical outcome question? Most of the value-based contracting that I'm familiar with often has to do with issues around either utilization or outcomes, and outcomes are probably usually population-based. So I think that's it. I guess maybe one of the things I should say, if folks are interested about readiness for value-based care, I do have a link I can send people to that's actually an online readiness for value-based care that takes your organization through readiness in 8 different dimensions. Please let me know, and I'm happy to forward that to you.
So we can also link that on our website if you wanted to send that to me. And a couple of people are chatting, yes, they would love that link. Do you have time for one more question, Lisa, if we're able to get a person on the phone who raised their hand?
I'm fine, time-wise.
Oh, perfect, thank you. Let's see if Yvette has her hand raised. Yvette, would you like to speak? I'm going to unmute you if you would like to speak your question. So Yvette, you are unmuted. Maybe it was an accidental hand raise. Okay. Well, it looks like those are all of the questions. I want to thank everyone again so much for logging in this morning, and I also want to thank you, Lisa, for sharing your experiences and for preparing for this webinar. This has been tremendously valuable for us, and I hope for our audience. Please do take a look at our website afterwards for some of these links, and the slides. We'll send you the recording to today's presentation. Please fill out the post-webinar survey to let us know how we're doing. We're always trying to improve the offerings that we have. But other than that, I would like to wish everyone a fabulous rest of their week, and thank you again so much.
Hello?
Hi, Lisa. We can still hear you.
Okay.
Did you want to say something too? As a goodbye, a farewell.
Oh, no, I didn't know. I'm assuming people are off.
Oh, okay. We'll have to close the webinar, but we will be in touch with you over email after this. And if you have any more questions too, please feel free to submit those to us via email. But thank you so much, Lisa. We really appreciate this. This has been a wonderful conversation. Yeah.
Oh, good. Yeah, sorry we ran a couple minutes over. I actually had one clock that my 2 clocks were different. I realized when I looked at one that it was a couple minutes slow. So
not a problem. It's on us. Go ahead.
I'm sending you that value-based care tool link right now.
Perfect. Thank you. And I was just going to say, it's on us to keep us on track on time, so don't even worry about that at all. And I think it was really valuable for people to hear. So, all right, I'm going to go ahead and log off now.
Okay, great.
Thank you so much, Lisa. Have a great rest of your day.
Thanks, you too.